Currently, I work as a metabolic health specialist. I'm a weight loss doctor working in Brockton, Massachusetts, in the US. Back about 8 years ago, I was at my biggest. I used to weigh 306 pounds with type 2 diabetes and a hemoglobin A1C of 8.7. I had obstructive sleep apnea with a CPAP machine, high cholesterol, high blood pressure, fatty liver disease, and binge eating disorder as well. And at my biggest, I was actually a primary care physician. So I was giving people advice about their weight and about metabolic health and comorbid conditions that come with obesity, having been 306 pounds myself. And so I was definitely not practicing what I preached. So basically, if you want to balloon up to 400 pounds and die of a heart attack, you can do that, right? Like it is an option and a choice. So basically signing up for a drug like Zepbound or Wegovy or Ozempic or Mounjaro is signing up for the potential of feeling stuck on the medication. But how does someone learn how to eat long term, learn about their body type, learn about like hormone imbalances, insulin resistance, metabolic health? You can't learn about that stuff if there's a shot first and then trying to learn the diet later. It should be like dietary intervention first, then that is one of many tools. The way intermittent fasting is a tool, that is one of many tools that can be added into the program. I've heard people say this at conferences, that if they are not in ketosis or a certain level of ketosis, they simply will not lose body fat. And that's just not true.
Hello, everyone. This is Nayiri from Low Carb and Fasting. Well, my guest today is Dr. Kevin Gendreau. I've interviewed him before, so that interview link will be below. Check that video out too. I have him again because I wanted to discuss his most recent book. And here's the title. The link will be below. Go ahead and buy that book, please. The title is Metabolic Health Handbook, a doctor's guide to overcoming the hormonal and biological barriers to fat loss. Dr. Kevin Gendreau, welcome to Low Carb and Fasting.
Hi, thank you so much for having me back. This is amazing. I really appreciate it.
I'm so looking forward to discussing the book. Before we do that, for anyone who hasn't heard of you, can you give us a quick sort of biography, please?
Sure. So currently I work as a metabolic health specialist. I'm a weight loss doctor working in Brockton, Massachusetts in the US. And how I came to be a weight loss doctor is basically I have a weight loss story of my own. So back about 8 years ago, I was at my biggest. I used to weigh 306 pounds with type 2 diabetes and a hemoglobin A1C of 8.7. I had obstructive sleep apnea with a CPAP machine, high cholesterol, high blood pressure, fatty liver disease, and binge eating disorder as well. And at my biggest, I was actually a primary care physician. So I was giving people advice about their weight and about metabolic health and comorbid conditions that come with obesity, having been 306 pounds myself. And so I was definitely not practicing what I preached. And so after my sister was diagnosed with cancer, I went through a weight loss journey of my own where I dropped 120 pounds with low carb and intermittent fasting. And then I switched from specializing in primary care and family medicine over into obesity medicine. I got certified by the American Board of Obesity Medicine, and now that's what I do full time.
Kevin, I really love the book. It is a handbook. You called it a handbook, and it is so the first people, please go and buy the book. I have the Kindle version because it's easier to travel with. I always have it on my laptop. So I love that you giving all the science, explain the science of, if you like, therapeutic carbohydrate reduction in the first kind of part of the book. And the second part of the book is how to do it, how to implement it. You've got all the recipes in there: breakfast recipes, lunch recipes, dinner and snack recipes. I love that. But what I loved about it most is that you use the word fat loss in the title. Was that conscious decision? Because I often use the word fat loss. It's not necessarily weight loss that we want. We specifically want fat loss. So can
That's
you
right. Very
explain?
conscious decision in the
Mhm.
title. Part of that comes from, being a weight loss doctor means that some of my patients take GLP-1 agonist medications. And although the book like very thoroughly focuses on which lifestyle interventions are best for people with insulin resistance, there are discussions in the book about if you are going to take one of these GLP-1 agonists, these injectable weight loss medications, the consequences of that and how you have to eat if you are on one of those. And so the reason why fat loss is in the title is because so many people are losing weight on GLP-1s, but they're losing muscle mass in addition to fat. And so like I want the focus first and foremost to be on what lifestyle changes need to be followed, whether you're on one of these tools for weight loss or not. And then also make it very clear that the goal is obviously fat loss and not overall weight loss. The scale is just such a rudimentary way to look at someone's metabolic health. And of course, you have celebrities who would be considered morbidly obese when really they're, if you do it by BMI criteria, when really they're in great optimal metabolic health with 8% body fat. So fat loss is definitely an intentional inclusion in the title.
Yeah, I like that. Oh, it was the first thing I noticed. I thought, oh, fat loss. This is because I've been using that as well. And there is a distinction between, what the scale shows. Scale doesn't know your fat from your muscle mass, for example. Okay. In chapter 1, you're talking about nutrient dense foods. You're talking about the healthy fats, which I think most of my audience will know by now that, nutrient dense foods aren't your carbohydrates. Mostly they're not your pastas and the croissants and the donuts. They are your healthy fats, healthy proteins. You do include fiber there. So let's just talk about nutrient dense foods.
Yeah, so the way that I introduce myself to patients, like the first time you meet me as your weight loss doctor, is actually in a group setting. So patients come in, it's usually between 10 and 15, and their introduction into this metabolic program is me talking about, and it's usually like a very clear discussion about what insulin resistance is, how our bodies as insulin resistant individuals work differently than others, and what dietary interventions we can use and should use if we have this body type. And I always make it very clear that like we live in a free country, free-ish country, right? So basically, if you want to balloon up to 400 pounds and die of a heart attack, you can do that, right? Like it is an option and a choice. But I try to make it so clear that if you happen to be someone who has a family history of type 2 diabetes and sleep apnea or PCOS and that type of genetics run in your family, then you are going to be more prone to an insulin resistant body type and weight gain if certain food groups are in your life, like if they're in your day-to-day life. There's obviously super insulin sensitive, skinny mini type individuals that can eat whatever the hell they want and they'll always be a size 000. But that is not me, right? That's how I got to 306 pounds. I'm obviously not genetically blessed in that way. And the people who come to see me are also not super insulin sensitive individuals because they're seeking out professional help from a weight loss doctor. And so the majority of this like 90-minute shared medical visit is making it very clear that there are certain body types like ours that are insulin resistant and that do not respond well to processed carbs and refined sugars. And so our primary food intake should be protein, fats, and fiber. And so those three food groups, in terms of like what food groups are most compatible, definitely protein, fats, and fiber are much more compatible with insulin resistant body types than processed carbs, refined sugars, starches, but even like natural sugars. And I even talk about that. Things like agave and honey and maple syrup, they're kind of like veiled as health foods, but unfortunately with body types like mine with insulin resistance, you don't really have that option, even if it is a natural source of sugar. Things like mangoes that are like 40 plus grams of sugar in one mango. It's like, yes, that's great. And if your kid wants to eat a mango, I wouldn't stop your child from eating fruit. But if you're sitting in front of me at 350 pounds with insulin resistance, there's a lot better fruits and a lot better options in the fiber department that'll be more compatible with your body.
Yeah. Oh, yeah. That resonates with me as well as a type 1 diabetic. Obviously, I'm wearing my Dexcom. The agave. Like I actually have used agave before and honey to treat my hypoglycemia. I mean, it's it's a good treatment. It's sugar. Sugar is sugar. So yeah, yeah, before glucose tablets, like yeah, take the honey jar and a few spoons, and you're back to normal again. So it's kind of a hypoglycemia treatment, if you like. So if you have diabetes or if you're suffering from any of the conditions that Dr. Gendreau was mentioning, then agave or honey are not your friend.
Right. And it's very hard to convince people of that. So a lot of this first visit is basically a deprogramming session. Like, I know you've been told that whole grains and honey and agave and low fat yogurts are so good for you. But unfortunately, when they take the fat out of the yogurt, they replace it with sugar. And unfortunately, whole grains are pretty much only okay if you're an insulin sensitive person with like no genetic history of diabetes or obesity.
Um, I have a personal story of whole grains too. I mean, when I was diagnosed with type 1 diabetes, it was 1978. So it was before glucose syrups came about or glucose tabs, and my mom didn't have any of those. I mean, these fancy sort of flavored glucose raising stuff. So if I ever had sort of hypoglycemia and I tell my mom I'm shaking, I'm not feeling well, guess what she would bring me? She would bring me sandwich, bread.
Yep.
She would bring me bread, and within 10 minutes I was back to normal again. How did that happen? Because bread breaks down into glucose, right? It's
Yep.
it's hard to convince people. It's hard to visualize it, isn't it? You can't blame people because it's just hard to kind of think of bread that way.
As sugar, exactly.
Sugar.
And it's also hard for people who have, if there's a 60 or 70-year-old who's dieted for the last 40 years, what they've been taught is like based around either the food pyramid or my plate, which we know that USDA guidelines are like very outdated and not very accurate for how the average person living in this country should be eating. So the food pyramid was like 6 to 11 servings of grains per day. And so people think you're supposed to start your day with cereal, you're supposed to have a granola bar for a snack and a sandwich for lunch, but don't worry, it's on wheat bread, right? Or like, oh, I'm going to have rice for dinner, but don't worry, it's brown rice. Like, your body doesn't know the difference in color. And unfortunately, your body doesn't know that there's slightly more fiber in brown rice than white rice. And it's just going to spike your blood sugar either way.
This is my favorite quote from the book. And it's going to lead to my next question. I'm going to read it out. Remember, this isn't just about dropping a few pounds. It's about resetting your metabolism and building a foundation for long-term health. I really love this one. It's resetting your metabolism. What is metabolism? I think is going to be the next. What is metabolic health or metabolic syndrome, if you like, because
So
you do have
the
that in the
the
book.
best way to describe metabolic health is a system of processes that happen in your body that basically lead to fat retention or deposition or fat loss. And so it's like how your bodies and the cells in your body are utilizing energy. Are they utilizing that energy and storing it, or are they utilizing that energy for use in day-to-day activities? And that like day-to-day activities is your metabolism. And so what happens is when you're in like the classic standard American diet mode, your body has elevated glucose above where it's supposed to be. And this is not me accusing everyone of being diabetic. It's blood sugar of 120, say, on average. But we know that blood sugar should be much lower than that on average if you're in optimal metabolic health. So if your blood sugar is 120, 130 on average, you won't be diagnosed with diabetes, but you still have a problem brewing in your body. And that problem is your sugar's at 120, 130, then you eat some kind of processed food, bread, rice, pasta, chips, cookies, crackers. Now your sugar's gone even higher than that, and you're having an inappropriate release of insulin. Insulin is your body's hormone released from the pancreas that's used to shuttle glucose into cells for energy. The problem, I know you know a lot about insulin, but the problem is these people who have 120, 130 of blood sugars, they're having excess insulin production, and all that extra insulin means that your body is slowly but surely becoming resistant to the effects of that insulin, requiring more and more to accomplish the same task. Once your insulin is too high, it just becomes a fat deposition hormone. The way I describe that is you're breaking your metabolism. So by having extra glucose, extra insulin, now you're resistant to that insulin, and any insulin or glucose above that threshold is just helping your body to deposit excess fat. So the goal in going low carb is basically to just normalize your glucose levels and your insulin levels. And with that comes improvement in metabolic markers and also an improvement in the symptoms that come with insulin resistance, which is like fatigue, joint pain, brain fog, low energy, lack of motivation, decreased libido. All of those things start to improve once your blood sugar and your insulin levels improve. And then you asked about metabolic syndrome. Metabolic syndrome is very clearly defined as it has certain criteria set forth by obesity and endocrine associations, where you measure things like triglycerides and blood pressure and HDL and glucose and waist circumference. And if you have a certain number of those criteria, 3 out of 5, for example, you're considered having metabolic syndrome, which is like the most severe form of insulin resistance. So we use those criteria and a few others, like fasting insulin levels, as a way to determine, like, is this patient in good metabolic health or not so good metabolic health, and then how we're going to get them there. So every 6 months, we're checking things like HDL, which is high density lipoprotein or good cholesterol, triglycerides, which also comes back on your lipid panel, blood pressure, fasting insulin levels. So all of these things we're tracking over time to make sure they're basically all headed in the right direction as a reflection of that person's metabolic health. It's also reflected in body fat percentage and like weight decreases and things like that. But it's nice to be able to like measure blood levels and be able to tell that someone's in better metabolic health.
So as you improve people's metabolic health, are you seeing any disease reversal cases? Well, you obviously reversed your type 2 diabetes and a few other conditions. Are you seeing the same in your patients?
Yes. So actually, one of the easiest things that we track. So I get a lot of patients who are in the pre-diabetic range, like their A1C is 5.7 to 6.4. And so we like to track that. And we've just like started compiling our data because I have 3,000 patients. So we started compiling our data to see like what is the cohort of patients that drop certain percentage of weight, and of those patients that drop a certain percentage of weight, like say 10% in 6 months or 15% in a year, how many of them reverse their diabetes or pre-diabetes. And so when it comes to like type 2 diabetes reversal or putting it into remission, depending on how you like to use your verbiage of diabetes, um, yeah, we're seeing numbers like 10, 25% or more of patients that are getting out of the diabetes range and into the normal A1C range, or at least below 5.7. It's hard because it takes a long time to look at data like this. So it's not really something you can look at in just like 3 or 6 months. It's really like year-long, 2, 3 year-long data. And so at my current institution where I work, I've only been there for a couple of years, and we're only now compiling this like backlog of data to look at. So I don't have like numbers to cite yet.
Yeah, it's for those of you who are interested, again, I urge you to go and buy the book. But chapter 3 actually covers the lab results. And I love that you put fasting insulin in there. Fasting insulin, yeah, you say, so if it's under 10, it's good. If it's under 6, it's ideal. Or optimal, I guess. So
Yeah, do you agree with that? That's kind of like a contested number for cutoff. I don't know if you use the same numbers. So my reference that's cited in there is the Society of Metabolic Health Practitioners. They have handouts that they give to providers. And so that's like where those numbers come from. And that's what I have found in my own clinical practice, that when people are under 6, like they pretty much couldn't be in better metabolic health. And usually when they get into that like less than 6 fasting insulin, they're at their goal.
until recently, we didn't have we didn't have a statement or an agreed sort of consensus on the insulin result. I mean, Dr. Lustig, for example, mentioned something completely different from Dr. Bickman, and but I've always gone by the 10. You know, anything under 10, good, and then anything under 5 as being perfect. But yeah, yours kind of your identification isn't far off. So we finally have clear guidelines with the SMHP, and I'm thankful for that. And
Also, it's kind of funny, like squabbling or disagreeing over like 5 or 6 or 10. When people come to see me, they're like 55, 348, 260. So it's so funny to be like, I don't know if it's 6 or 7 or 5, because it's like so much better than where they were, that it's almost like it's kind of like when you lower your carbs, right? If you were eating 300 and now you're eating 70 or 60, but you're not quite at 40 or 50, it's like, well, it's way better than 300 grams of carbs a day. So probably you're going to lose tons of body fat.
yeah. Um, I mean, yeah, the highest insulin I've seen, I think, was in the 70, 74, 76. I haven't seen anything higher than that, but you
Oh
probably
yeah, we have
like,
some really crazy high
oh,
numbers. And then when I talk to people about what they're eating, it's so obvious. It's like a whole box of Lucky Charms for breakfast, 2 sandwiches with chips for lunch, and like an entire pizza for dinner. Boom, 380 insulin level. And like no surprise there, right? Like I'm 0% surprised. Triglycerides of 1,000 while we're at it, right? So it's like
oh.
increased risk of pancreatitis. They just didn't know, they just didn't know better.
They didn't know, but I'm pretty, I mean, they didn't know. Okay, I'll go with that. But I think most
No,
people
people know
that
pizza's
way,
bad and Lucky Charms is
they
bad.
know that these foods are bad, but there is a different urge. There's an addiction issue, obviously, and
Hmm.
also people cannot control their urge to eat, their hunger. And I want to tie that with fiber. I mean, I'm glad that you included fiber. It's again, fiber is not an essential nutrient, but it does have satiety inducing effects. So it
Right.
works for some people to include large amounts of fiber.
It's also especially helpful because I have the widest range of patients. So I don't really turn anybody away. If somebody comes to me and they want to be a 100% carnivore, red meat only, never look at a piece of broccoli in their life, fine. If somebody comes to me and they are like 100% vegan, never wants to look at an animal product, great. I'm not turning a patient away for anything like that. So that means like meeting people where they're at. And with a lot of patients who are in that like vegan end of the spectrum, there is no choice for them but to eat fiber, certain healthy fats, because they're not going to eat any fats from like animal sources, that's for sure. And their protein sources. I have like a separate list that I hand to vegan and vegetarian patients that are just vegan protein sources. And that's like lupini beans and peanut butter and vegan protein shakes and things like that. So kind of meeting people where they're at means that I'm going to have a lot of patients that are eating fiber and have a really hard time with the animal products. And so I know there's a lot in this space of being low carb. There's definitely so many advocates for carnivore diets and keto diets, or at least like animal heavy diets where 75+% of your intake is from animal products. And it's something that like can, of course, improve metabolic health. Like if you only were to stay carnivore, as long as your GI tract is working well with that, then of course your metabolic health is going to improve and all of your metabolic markers going to improve. I have hundreds of patients that are carnivores, but a lot of my job is meeting people where they're at. And that's in terms of diet, that's in terms of lifestyle change that they can handle. That's in terms of medications. So sometimes people come to me and they're like, I'm not leaving here without a drug, right? So as a physician, the best part of my job is deprescribing medications. Like I love when people come to me on 3 blood pressure meds and they drop 50 pounds of fat and now they don't need blood pressure medications anymore or cholesterol drugs anymore, or we get them off their diabetes medications. But part of my job is also using whatever tools are necessary or possible to use in these populations. So if I have a type 2 diabetic who is like staunchly in favor of being on Mounjaro, I will heavily walk them through exactly what dietary change they need to follow. And we can use a drug like Mounjaro, especially if the person has wildly elevated blood pressure, blood sugars, and like a food addiction problem, because those medications do help a lot with binge eating disorder and things like that.
Which ones do you use? Which are the most common ones?
So in patients who have type 2 diabetes with an A1C of 6.5 plus, we prescribe Ozempic, Mounjaro, Trulicity, and then patients who have anything less than a 6.5 A1C, they're considered insulin resistant, pre-diabetic, metabolic syndrome without the diabetes. They would be on something like Wegovy or Zepbound or Saxenda. So we're prescribing, like I have, it's just me and my nurse practitioner in the office, and we're prescribing medications to a portion of our patients, depending on how they present and their own like personal desires and what works for them.
Mhm. And so are they temporary or, are you putting people, because I think that would be, if I were considering any of those drugs, that would be my first question. Is this a lifelong thing or is this a temporary thing?
Yeah, I think there's like 2 different camps in this. So there's people who look at weight loss injections. So there's like the group of Obesity Medicine Association, Harvard, Blackburn, like these large bodies of obesity medicine that like created the ABOM, the American Board of Obesity Medicine. And they say things like obesity is a chronic disease and these medications are lifelong, in the way that patients who are type 2 diabetic, this is like the same group of people who will say you're type 2 diabetic, it's a lifelong disease that requires lifelong treatment, which is often inclusive of medication. Then you have the camp of like Low Carb USA, Society of Metabolic Health Practitioners, who are on the side of like, if you're gonna use a drug like a GLP, it should be like a temporary tool to get you to your goal, and then you kind of like wean off the medication or microdose it, or only basically only on it if you absolutely need it. I see both sides and I attend both conferences. Like I have patients who have such severe issues with binge eating disorder, emotional eating issues. They just lead stressful lives. Like it's a busy mother of 3 who eats her feelings, right? So that person has dieted a million times in her life, including keto diets, and it's like nothing has ever worked, but a low dose of Zepbound has kept her cravings and food noise at bay and allowed her the ability to now follow a low carb diet. It's not like you take a drug and eat pizza all day and you're skinny. Like we wish that that existed. There's no such thing, right? So really it's, does this medication keep their disordered eating patterns at bay and keep their food noise at bay? And if so, great. Maybe they want to come off of it after a year, maybe they don't, but we really do see an issue with coming off medications, because if your food noise is kept at bay and you're doing so well and you're at your goal, and then you get rid of that molecule that's binding to those receptors and decreasing all that craving for carbs, unfortunately, a lot of people gain their weight back. And if you look at studies like randomized controlled trials with these shots, 2/3 of weight regain is what we see. So you lose, say, 50 pounds, 2/3 of that 50 pounds comes back after cessation of the medication. In our clinic, because we take such a low carb focus, it is not 2/3 of patients gaining 2/3 of their weight back. It really is like a 50-50 thing. So about half the patients who stop the medication stay low carb, keep their being low carb, as you know, keeps your food noise at bay because you're not having these like wild swings in blood pressure, blood sugar or insulin anymore. So following a low carb or keto diet, like long term, is extremely helpful with being able to come off that medication. But then you have the people who, as soon as they come off, food noise returns and they feel like they have to go back on it, like restart it. So basically signing up for a drug like Zepbound or Wegovy or Ozempic or Mounjaro is signing up for the potential of feeling stuck on the medication, which is fine, right? Because there are these people who are on it long term, and we have longer term studies for drugs like Trulicity. 7 to 10 year data don't show any increased risk of cancers or anything like that. There is a black box warning for thyroid cancer, but it's not because of any increased incidence of thyroid cancer. So seems to be, what I usually say to people is, seems to be safe long term from longer term 7 to 10 year data with Trulicity, which is a GLP-1. And then I say, you are taking the risk of being on the medication for long term if you do start it, right? If you don't start a medication, you do lifestyle changes only with, say, low carb and intermittent fasting, then obviously you're not going to take the risk. But if you are starting a drug like that, there's a risk involved of, yes, you may end up on this long term, because without it, the food noise comes back.
I think I don't know if you see children, adolescents who are
I
obese.
do. We see 15 plus. So I used to do family medicine. So I used to see like babies and really young kiddos in my practice. But now with this clinic that I'm working in, like I work at a nonprofit hospital organization. And so their policy is set forth as age 15 plus.
And is it the same sort of strategies for 15 plus? Say a
Usually
15-year-old
with 21 or under, our primary intervention is, well, actually, no, with everybody, right? All patients are the primary intervention is lifestyle change. But we are much more likely to like reach for these tools like medications in an older group. If you do follow Obesity Medicine Association or any of the big boards of obesity medicine, they all say 13 plus to start injectables, but for no age group is injectable the first intervention. Like that shouldn't be, in my practice, it's not, will not be, has never been the first intervention. However, in many practices nationwide, hundreds and thousands of doctors and nurse practitioners nationwide, it's their first most important intervention are injectable weight loss drugs. But how does someone learn how to eat long term, learn about their body type, learn about like hormone imbalances, insulin resistance, metabolic health? You can't learn about that stuff if there's a shot first and then trying to learn the diet later. It should be like dietary intervention first. Then that is one of many tools, the way intermittent fasting is a tool, that is one of many tools that can be added into the program.
So, hormonal and biological barriers to fat loss. So, one of the most important hormones, and we discussed that, is insulin. And if it's consistently high over decades, maybe even a decade, then you are becoming hyperinsulinemic and therefore insulin resistant. That's clear enough. What other hormones play a role?
So it's not just about the insulin, even though that's such an easy. So I use insulin in explaining to patients because I think it's easiest to understand that like having extra glucose, having extra insulin, it's now a fat deposition hormone, you're now resistant, right? But if you get into all the biochemistry, we have ghrelin, the hunger hormone, we have leptin, the satiety hormone, we have GLP-1, glucagon-like peptide 1. That's the one that's involved and implicated with these injectable weight loss drugs. GIP, which is gastric inhibitory peptide, which is what Mounjaro and Zepbound bind to. So there are like a cascade of hormones involved in weight gain and weight loss, also including thyroid hormones. There's estrogen around menopause. Like, good Lord, there are so many things going on. And honestly, so many things going wrong when you're eating the wrong foods for your body. So if you're primarily looking at processed crap and that's what your intake is, then tons of these hormones, I don't know, 2/3, all of them are going to be out of whack. Like you're going to have an inappropriate release of ghrelin, the hunger hormone, if you're eating something like processed Chinese food and ice cream for dessert. You're going to have an inappropriate release of ghrelin, the hunger hormone, 2 hours later and already be hungry again. Whereas if you're having something like a 16-ounce steak, you're not going to be hungry 2 hours later because you have a great suppression of ghrelin, the hunger hormone. So I will touch on things like ghrelin or leptin, the satiety hormone with patients, but I don't even, is like, I've always said, is there even a need to get into the nitty gritty of biochemistry with each and every patient out of 3,000 people? Not really. You just need to know which foods are breaking your metabolism, right? Like you just have to know what things are ruining it. And the best way to explain it is with sugar and insulin, but there's obviously so many more. And there's probably more hormones we don't even know about because they're currently being like researched right now, like amylin, for example. Like there's all these hormones that they discover and research, and now they're trying to find like medications that bind to them to try to like decrease hunger, and it's crazy that the world of obesity medicine and the research that goes into it is crazy. And I don't even know where we'll be at, 2 years from now in terms of our understanding of like the GI tract and how it has a mind of its own. Like it has its own neurological system and its own hormonal system. Everyone always thinks of like the endocrine system when it comes to hormones, but the GI tract has its own hormonal system.
Yeah. Uh, it's quite complex. So in chapter 5, you're talking about ketosis. And I think you do, I think these are your words. So ketosis is not necessary for weight loss. Let's explain
Yes.
ketosis.
Okay. What did you say? Sorry. Explain it. Is that what you said?
Explain
Yeah,
ketosis.
the audio cut
Yeah.
out. So the thing about ketosis is I think that when I go to these conferences, they're often said to be like keto conferences or carnivore conferences, right? Sometimes they'll say low carb conferences. Never have I ever, with my 5+ years now of being an obesity medicine physician, never have I ever recommended, suggested, like forced or advised a single patient to check ketones. But yet we have such high rates of success. Like we're seeing an average of 27 pounds of weight loss in 6 months, 50 pounds of weight loss in a year. And most of this weight loss is body fat because we do body fat composition analyses. And so these crazy high rates of success that we see and compliance with low carb are never to do with measuring ketones or specifically eating high fat diets. And I think sometimes people who follow ketogenic diets focus so heavily on the fat. Like I'm sure you've seen this in the space where it's almost cultish, like people bragging about all of the MCT oil that they're sipping on and all the butter that they put in their coffee and how much fat they eat. But they're like losing sight of, with all the focus on fat, they're losing sight of the fact that it's what they left out is the reason why they're losing weight. So it's the fact that they're not eating sugar and carbs anymore, not the fact that they are eating 100% of their intake and calories from fat. And so the reason why I try to like take the focus away from high fat and the focus away from calories in general is because I want it to be very clear that there's these food groups that your body that are compatible with your body, like things like protein and fat are compatible with your body. And then there's these food groups that are just like not compatible because every time you're eating them, you're having this inappropriate response of glucose, inappropriate response of insulin. So it's not that like ketosis is useless. It's really just where's your focus at? Like, is your focus on I have to eat a certain amount of fat today? Or is your focus on I just have to stay under a certain number of carbohydrates today?
Mm-hmm. And so, yeah, ketosis is not necessary for weight loss because, or at least let me put it this way. I mean, even if you are doing a carnivore diet, um, uh, which isn't necessarily a weight loss diet, but but you are going to be in sort of very low level of ketosis pretty much the whole time. So your body will be burning fat at least some of the time. So I mean, ketosis in my community, again, I think is so misunderstood because people think they're not going to lose weight if they eat high protein. They need the fat. They need to be in high levels of ketosis to lose
Yes,
weight.
yes, yes. I've met
And
people
we
like
don't
that
see
think they
that.
can't eat protein. Yes.
Exactly. So fear of protein as well. And because for at least for type 1s, we're going to need injection for proteins as well. So we're going to need insulin for protein, but the context matters. if you are taking insulin to build muscle because you have had a whatever, however many ounces of steak, that's a completely different context than taking the same amount of insulin to cover your oatmeal, right? And so it's not as simple as, high levels of insulin, you're going to be fat, and, and ketosis is necessary for weight loss.
Right. I think that's like a simple way to look at it. But unfortunately, I feel like so many people do look at it as such. Like they feel like I've heard people say this at conferences that if they are not in ketosis or a certain level of ketosis, they simply will not lose body fat. And that's just not true, which is also very similar to what you hear about calories, right? Like if I'm not under a certain amount of calories, I will not lose. But as we know, like calories, the more we learn about the way a calorie works in the body, it's just not, it's such a simple way to look at the human body. Like it's like treating us as a perfect math equation. And we all know that it's not like that. Like there's all these hormones that we were just mentioning. And if all of these hormones are involved, then clearly we can't be a simple, calories in, calories out math equation, because you don't take into account hunger hormones or fat deposition hormones in number of calories.
Mm-hmm. I mean, it is understandable, of course, for some people with certain neurological conditions who have to maintain a high level of ketones for brain health, for epilepsy, and other kind of reasons.
Yeah, it's been shown
That's
to
a
be
different
helpful for
situation.
migraines, brain metastases. Like strict ketosis is not useless. I just don't want people to think that they have to do
Yeah,
strict ketosis?
yeah. Okay, people, if you're confused about what you can buy, get Kevin's book, open to chapter 6. There's your grocery list in there. So take the book with you and go out to your wherever. Where do people go shopping, grocery shopping in the States? It's not Target, it's a Trader Joe's. So head to Trader Joe's for
Yeah, they go to Trader Joe's. They
your
go to Target. I go to Target myself for shopping. And
right.
honestly, I get a lot of stuff on Amazon. I'm not gonna lie. Like a lot of the things that are low carb, I don't even have a choice but to order on Amazon because I just can't find it around me. I don't really live near a Whole Foods or Trader Joe's though.
I do the same in the UK, so I rely on Amazon. But hey, so you got your grocery lists in there in chapter 6 and chapter 7. Mention some food swaps. So if you're not going to use, I don't know, wheat flour for your muffins, doesn't mean you can never ever have muffins. Dr. Gendreau suggests a swap for wheat flour, right? So what are
That's
some
right.
of
Put
the
almond
most
flour, coconut flour. Although I do tell people when it comes to like the low carb desserts, just be a little careful because I feel like if you are triggered by sweet kind of foods, like you could easily binge on 12 quote unquote keto cookies, right? And then all of a sudden it's like, why didn't I just eat an Oreo? Like after all of this, I should have just had the bad thing because I ate 2,000 calories and 200 grams of total carbs in low carb cookies. So you have to be careful with those kind of swaps. But I like the pasta swaps, the rice swaps, because there's all these things like konjac root and miracle noodles, and they make noodles out of eggs now, where it's like basically like eating a hard-boiled egg, but it's in noodle form, which I think is so cool. So yeah, I feel like that's like that chapter 7, is like a very much work in progress. Like I'm constantly that's one of the handouts that I give to my patients, and I'm constantly adding to it because a patient will come to me and be like, oh, look, I found these wraps that are made out of eggs, or these wraps that are made out of spinach or whatever, and I look into it and research it, check the total carb count. The thing that I find crazy about products that really makes me nuts is the number of companies that get away with calling something keto, which is another reason why I get nervous about this, like the keto craze, is because people buy keto bread and on the front it says 1 gram net carb. So then they buy it thinking, well, it's 22 grams total, but it's only 1 gram net. There's so much fiber in it. And I'm like, what is that fiber? Is that real like real fiber is when you snap a piece of celery in half and you see fibers. Like the fiber that is in that bread is not the same type of fiber in a vegetable. So you really can't like take it to heart and take it as truth, but these companies get away with it. And so you're eating a sandwich on bread that says one net carb per slice, and you've had 44 grams of total carbs, and as if your body knows what the hell a net carb is.
And quite often the sort of those products have say completely something different on the front. And then when you check the ingredients, it just doesn't even add up. It doesn't really,
I know
diabetes.
it'll say like
Yeah.
made with cauliflower, right? But the cauliflower is like the eighth ingredient. Like, okay, well, technically, I guess there's cauliflower in it. How do you get away with that?
Or sugar-free at the front. And then you find out 80% of your product is actually sugar, but it says sugar-free, as in
Right.
no added sugar. It's like, come on, it's
It's sugar free, just made out of coconut sugar and agave.
exactly, exactly. What's your favorite breakfast to start the day with? I'm gonna put it.
Well, I actually do still do intermittent fasting myself. So part of my weight loss was dropping my carbs to like below 40 to 50 total carbs per day. And then after dropping about 75 pounds, I read The Obesity Code by Jason Fung, like so many of us do. And then I started doing intermittent fasting. And so my window is usually 6 hours. So I typically will eat around 12 and then around 5:36. But on the weekends, I will often have breakfast, and my favorite breakfast is veggie omelet, like spinach, peppers, and onions with eggs. I'll usually get like 4 or 5 eggs and then a side of bacon.
What's your favorite lunch?
Lunch is a little random, but what I typically will do is I don't do like a sit down lunch because I'm so busy at work, and some days I'm seeing like 30 patients. So I actually like work through lunch. So I have to have something pre-made, quick, easy. So what I'll typically do for lunch is something like a yogurt with nuts and berries, and I'll make my own chicken salad with just like chicken mayo seasonings, maybe some onions or celery, and I will actually like dip celery sticks or carrots in it or cucumbers. And so it's typically some protein from yogurt and chicken, and then there's like some fiber sprinkled in.
And dinner?
My favorite dinner, let's see, like recently, my favorite dinner has been I really like to make like a meat sauce, so like a bolognese sauce. So I'll make like a ground beef or ground turkey into like a red sauce. And sometimes I use it with taco seasoning. And cheese crisps, like there's this brand called Wisps. They make like little cheese crackers that are just cheese that's baked in the oven. I make my own little cheese crisps in the oven. The recipe's in the book, and I kind of just like scoop the ground beef like taco. So it's kind of like little mini tacos, and I'll put like sour cream on top.
Perfect. So if that didn't tempt you to go and buy the book, I don't know what would. So I'm just salivating hearing all these now sitting here. Thank you. Thank you so much for your time today. I really appreciate this, and we should do it again. When are you publishing your next book?
Oh my gosh. Funny you should ask. What I'm currently working on is me and actually a patient of mine are working on a cookbook together. So my mother's side of the family is Portuguese. They hail from São Miguel, Saint Michael in the Azores, Portugal. And so we're working on a Mediterranean Portuguese infused cookbook. And so my personal story will be in that cookbook. And then this other mystery person that I'm writing it with is going to have her own recipes and her own story in that cookbook. That's what I'm currently working on.
Oh, that sounds fabulous. I'm looking forward to that already. Thank you again for your time. I wish you a beautiful day. Your day is
Thank you
just
so
starting,
much.
right? Thank
Yeah, it's 11 a.m. Thank you so
you.
much for having me.
Bye-bye.
Bye.